Hello and welcome to another edition of The Front Page on GNet TV. I'm Andrew McKeever, the managing editor of the Manchester Journal. It's my pleasure to be your host today. The landscape of healthcare in Vermont and the role hospitals play in that has been a subject of great interest to Vermonters and all of us around the state in the last couple of years as we've seen the arrival of the Federal Affordable Care Act, better known as Obamacare to some, the passage of Act 48 in 2011 by the state legislature here. And it's been quite a subject that continues to evolve as the state has moved through its sometimes rocky adoption of Vermont Health Connect, the online health exchange that's been set up in the wake of the Affordable Care Act. Here to talk to us today about those issues and other things is Bea Grause, who is the President and Chief Executive Officer of the Vermont Association of Hospitals and Health Systems. Bea, welcome to GNet.
Andrew, thank you so much.
Great to have you here, and thank you for making the time and coming down from Montpelier to be with us to talk about these very important issues that I know are of great interest to all of our listeners out there. Just to kind of get things started, I wondered if you could sketch out for us sort of the big picture of where hospitals are at these days in Vermont. Looking back from the present to, let's say, 5 or 10 years ago, would you say hospitals are, pardon the pun, healthier than they were then, or still struggling with some challenges?
Well, I think there are always challenges. I think hospitals in Vermont are healthy, financially healthy, they're financially stable. But with the passage, as you said, of the Affordable Care Act in 2010 and Act 48 just a year later, hospitals are really on the edge of a lot of change, anticipating a lot of change, both on the financial end with their payments, because the federal government and the state government want to change fundamentally how they are paid, but also on the care delivery side, because they have to change and improve how care is delivered so that they can reduce costs and live within those new payments. So lots of changes in the works.
Mm-hmm. Now, one of the issues I keep hearing about when we talk about hospitals, health insurance, healthcare is the cost shift question, where
Sure.
Health insurance payments for those who have health insurance policies are higher than they would be because they have to offset those who don't have any health coverage or Medicare, Medicaid payments that are not adequate to cover the hospital's costs. A few years ago, that seemed to be a major problem and something that came up all the time whenever I talked to a hospital administrator. Is that situation getting any better now?
It's not getting any better, but it is definitely on our to-do list of something we want to begin to address. It's part of, for consumers, if they have commercial insurance, they're paying retail plus in a way, because they're picking up some of the underpayments that Medicare and Medicaid don't pay. And so part of our plan to move forward on payment reform across all payers is to over time reduce that disparity between the underpayments of government payments and the overpayments of commercial payments that drive up commercial premiums. So to try to narrow that gap a little bit.
It's always puzzled me as to why the government is so, it seems like on one level, stingy about that. I mean, why isn't it possible for the government to say, okay, well, this procedure is going to cost X amount of money, and therefore that's what will contribute to the hospital? I mean, why does that gap exist?
Well, they do have that. They do pay, they do set, unilaterally set a payment and say, well, for this office visit, I'm going to pay you X. So they do that today, just as that X doesn't cover the cost of the service. That's the problem. So, and again, part of what we are trying to get to would be, a set of prices, so to speak, that are consistent across all payers. So, okay. And again, it's probably never going to be exactly the same, but closer, so that for example, Blue Cross isn't paying, I'm making up these numbers,
right,
but Blue Cross isn't paying $100 for an office visit and Medicaid is paying $40, so that we're going to narrow that gap a little bit so that it's closer to, 80 and 70, something, again, I'm making up those numbers, but that's the general goal, is to try to bring prices closer to the cost of the service for all payers. Because again, I think that would help. It's such a crazy system, no one can understand it. I can barely understand it, and I've been working in it forever. But to get some, normalize it in a sense, where it becomes more understandable for Vermonters, because as taxpayers, we're paying for all of it. And as consumers, over time, we want to help consumers understand how the healthcare marketplace works for them, including the financial aspects. But the delivery side is complicated too, but the combination of the two is almost impenetrable currently.
One of the trends that seems to be happening, at least it seems to be prominent down here with Southwestern Vermont Medical Center in Bennington forming an alliance with Dartmouth Hitchcock Hospital over in New Hampshire, is this idea of consolidation of services.
Yep.
I'm assuming that around the state, several of your other member hospitals are also looking at partnerships with other health providers. Is that big true, or?
Absolutely, Andrew. It's true across the state. It's actually true across the country, and it's part of what we were talking about before with the Affordable Care Act and Act 48, where the federal government and the state government want to limit their financial liability. So they want to change fundamentally how hospitals are paid, and other providers too. But I'm just speaking for hospitals. But currently hospitals are paid by transactions. So we call it fee for service, but it's your basic transaction mechanism. So you provide a service, you get paid for the service. You provide a service, you get paid for the service. And so that payment methodology drives an incentive to do more. And over the decades, we have created a healthcare system that is built on that volume kind of incentive. We have an aging population. Vermont is the second oldest state in the country. And we all, as we're getting older, are going to use healthcare services whether we're healthy or not healthy. We just do. And so that the combination of that is like a perfect storm. And so changing this payment transaction system to a payment system where that is more kind of back to capitation, where the federal government and the state government will say, well, we'll pay you X amount per person who we are covering. So we'll pay you $100 a month, and again, I'm making up these numbers, for the Medicare beneficiaries in your area. You provide all of the hospital services for them, but that's all you're going to wind up getting paid. And so the hospital then has the incentive to provide services in a way that will give the services to the beneficiary that they need, and not but just enough services. And I just want to say too, also that it's capitation, but I call it evolved capitation, because the hospital and other providers will be required to report on measures to make sure that they're not undertreating, but that they're providing the right level of services for the Medicare beneficiary or the Blue Cross beneficiary, so that they can achieve their health goals.
One of the things that I've heard a lot about and read about in the media is that hospitals have been criticized, and doctors I guess as well, for running too many tests. That they kind of, I'm not sure if the purpose is to drive up the bill or if it's just to make sure that they've tested every possible scenario so that they're sure that when they discharge a patient they're as well as they can be. But do you think there are incentives that are built in so that hospitals are kind of encouraged to maybe overdo it on the testing side?
Sure, I think there are I think there are several things going on. I think one of it is the fee-for-service system, and again, that becomes kind of part of the culture. I think the other thing is liability, concerns about liability, and the third, I would say, is technology. Often you will have, for example, a patient who has chest pain, goes to a critical access hospital, and they suspect maybe they want to rule out a myocardial infarction or a heart attack. And so they transfer that patient to a larger facility, maybe Fletcher Allen or UVM Medical Center or Dartmouth, or Rutland even. And the patient goes there and they've had a round of tests, but then the physician wants to repeat the test because there's not a way to electronically transmit those. So part of it is communication, part of it's liability, and I think the culture of doing as much as we can for the patient in the moment without looking beyond longitudinally about where was the patient going, where did they just come from, and what do they really want? What do they really want in the long term? So maybe an extra test doesn't make any sense for them. So we tend to have a system where the provider is very focused in that moment rather than taking that broader view.
You mentioned technology, and that's another area I think hospitals have been trying to push towards. How is that going? I mean, again, there was money, I think, in the Affordable Care Act to help assist hospitals sort of to communicate with each other, online and what have you. Is that process moving forward as well as you would like?
Yeah, I'm not a technology
You're not a
geek,
techie,
so
huh?
I'm a lawyer, so here's my disclaimer. But it's a challenge. I think, hospitals have a long, painful history with health information technology. I think every hospital in the country has I call it a legacy system, where it's one piece is done, then they patch on a new piece and they patch on another piece. And for some facilities, I think we're pretty good here in Vermont. Your outpatient department might not use the same software as your inpatient department, and so it's all patched together with bubble gum and chicken wire. So we still have to, in order to get to a better place, we still have to start from where we are. So the federal government about 5 years ago passed the acronym is ARA, and I'm blanking on what that means, but it was the bill that passed, the Economic Recovery Bill, that passed after when the recession started.
Yeah.
But in that bill was federal dollars to help hospitals subsidize the transition to electronic health records. And so that has been a good thing. That has helped. And so we've made some progress. Some of the barriers that still exist is that we're still lacking a lot of federal standards that all the vendors who are installing those electronic health records would have to abide by federal standards for security, transmission, all of those things. So that we're still kind of stuck, connecting all these disparate, different systems in a way that I think is a little clunky and expensive. So we'll continue to evolve. It's not, we can't evolve our delivery system without having real-time ability to talk to each other. And frankly, now we all have our smartphones. We just have to figure out how, there are federal laws around privacy. So that's part of the complicating factor. You can't just email, on your phone, your medical record to somebody else, because the federal law prohibits that.
Right.
So complying with federal privacy laws and security laws and figuring out a way to transmit that information is something we're definitely working on. It's just a hard job.
I bet. Yeah, it sounds like newspapers actually to me. One of the things we were talking about before we went on the air was wellness programs, and I know that's a major area for hospitals to be focusing on. What is the general overall health of Vermonters? I mean, I've read conflicting studies about that, and it probably varies from different parts of the state to others. I mean, a few years ago, I ran across a set of statistics that indicated that Bennington County, or down here, was one of the shall we say, poorer performers in terms of overall healthcare metrics.
Yeah.
Is that still the case, and are we making any headway? And again, what role is hospitals playing in helping to move the trend in the right direction?
Oh, there's a lot in that question, Andrew. So
let me unpack that one.
Yeah. So let me unravel it a little bit. I think that often if you look at national reports that rank states on their health, Vermont is usually one or two. But I often say we're kind of at the top of a crappy heap in that we do have significant health challenges that I think we need to work on. We're part of a national obesity epidemic. Associated with that, we have increasing both adult and pediatric diabetes. Smoking is still an issue. Substance abuse is an issue. Mental health issues remain a challenge. So there's a lot to work on. Are we getting healthier? I don't think we're getting less healthy, but I don't think, I think it's a long, slow climb that's going to take a lot of work. Now, you asked the question, what are hospitals doing to help with that? That's a big part of what we are very excited that we're working on. As I said to you before, we're developing a plan with the state of Vermont and the federal government to change how we're paid. We learned from the 80s and the whole managed care era that you can't change payment without changing how you're delivering care, because the two are interconnected. And how we're changing care and hoping to help make Vermonters healthier is that we are evolving and starting with primary care, and we've been working on this for a while, but evolving initially the primary care setting, which again used to be a very siloed setting, and bringing in resources such as a nurse, a behavioral health specialist, a nutritionist, into practice what I call team health or a medical home. So that when a patient goes to the primary care doctor, they actually have a medical home. So they have a whole team of people who are preparing for that individual to come in. They're getting screened before they even go to see the doctor, gives the doctor a lot more information, prepares the doctor actually to see the patient. And then when they're finished, if they need follow-up, then they have an actual person that they go to make sure that they're going to go see the mental health, go get their counseling appointment, that they'll get their appointment with the dietitian, or they'll see the dietitian immediately afterwards if they want to set some goals around losing weight or managing their diabetes better, whatever the challenge is. So it's more of a team approach to just make sure that we're engaging Vermonters in helping themselves get healthy, because every Vermonter is the quarterback of their own health. And that's, you can go to the doctor once a week, but you're still making tons more decisions about your health than your doctor is. So that's more of the approach that we're starting to keep in mind. To build on that medical home concept, and Vermont is leading the country in that most of our primary care practices are now medical homes. And you may be familiar with the term, it's the Vermont Blueprint for Health, but that's the base that we are building on in terms of delivery reform. And we're trying to go from medical homes to medical neighborhoods. That's the general concept. And the concept there is that, Vermonters, when they have a medical condition, the origin of that medical condition might be social, not medical. So looking more broadly at a team of people in a community, both social providers, the state of Vermont, the AAAs on aging, housing professionals, who can work together as a team to identify those Vermonters in this local area who are most at risk of, perhaps because they don't have stable home, they can't afford their medication, there are many reasons, and work as a team to try to figure out how to manage their health and their social situation better so that we're reducing medical spending. So I think a typical example is, someone, not typical necessarily, an example is, someone who may have a mental health challenge and is in and out of housing, to try to address that core need so that they're not showing up in the emergency room twice a week for one reason or another. So trying to, take that more holistic approach. So, and in fact, Southwestern Vermont Healthcare has been a leader. They were a leader in the medical home effort, and they were a leader in the medical neighborhood effort too. So it's a great
I've often wondered if there was some way to build incentives for wellness into insurance policies. I mean, no smoking or sort of forcing smokers to pay more for their health insurance would seem like an obvious no-brainer, but even that has been difficult. And then to try and encourage folks who may be struggling with obesity issues would be even more complicated and judgmental. But is there any way, or has there been any discussion within among your colleagues about how that might happen or how that could be structured so that if someone chooses to smoke or chooses to be overweight or doesn't exercise at some bare minimal level, they in effect pay a penalty for that? And do you think would that encourage people to kind of
Well,
right
in my world, there are two general policy options. You can have carrots, which are positive incentives, or you can have sticks, which are, like if you don't do that, you're getting a penalty. So insurance, I believe, already has carrots. I don't know of any. I don't know of insurance policies that might have sticks like a penalty. I read about it periodically, but in Vermont, I'm not aware of any. There doesn't mean that there aren't. I'm just not aware of any. And on the obesity question, boy, if someone could figure out a way to prevent or most effectively treat obesity, they would win some,
some major award,
Nobel
or
Peace
make a lot of
Prize or
money.
something. I don't know, but preventing obesity, I think they're still researching. Treating obesity, I think one of the things that we're finding with the work that we're doing in medical homes is a lot of it is about goal setting, relationships, and engaging a patient and figuring out what motivates them. So again, I think it's having that coaching relationship, whether it's with a nurse who happens to be a part of the medical home or the physician, to help the individual set goals and then have that ongoing relationship so that the person remains motivated. I think that's the theory around Weight Watchers. That's certainly still an option as well, but it's really around that coaching and caring model to help the individual set their own goals.
Okay. I suppose it'd be impossible to have a conversation like this without at least talking a little bit about Vermont Health Connect. They've, as I said at the start of the show, they've been in the news a lot, and for all the wrong reasons a lot of the time. Although I gather they're trying to hopefully straighten those things out. But how have hospitals been affected by the ups and downs of Vermont Health Connect since it launched back in October of 2013?
Yep.
Was it difficult for hospitals to kind of get in alignment with the health exchange, given the ups and downs that they went through?
No, I don't think that part was difficult for hospitals. Probably more for the payers, because they're putting products on the exchange. But for hospitals, it was an overall plus because more people wound up getting insurance, and that's always a good thing. And that's certainly a goal that, as I said before, getting every Vermonter covered with insurance is something we think is a must happen in healthcare reform. And Vermonter hospitals, have been working to help Vermonters figure out whether if Vermont Health Connect makes sense for them, or whether or not they'd be Medicaid eligible. So they've been helping Vermonters navigate on those kind of that decision-making tree on if they want to purchase insurance, what is the best plan for them to purchase, what would be their financial obligation, are they eligible for subsidies on the exchange, or are they even eligible for Medicaid? So they've been helping to enroll people it's called point of service. When they actually come to receive hospital services and they don't have insurance, we'll help them figure that piece out. So that's one thing that we have been doing. So as far as what's going to happen with Vermont Health Connect, I think that remains to be seen. The big problem there, as we talked about before, has been IT. It's not easy for anybody. I mean, so they've been struggling really on the back office end of making Vermont Health Connect work seamlessly from the website all the way through the enrollment process, change of circumstances, all the payment, how the payments are calculated and then transmitted. So all of that still needs to work, and the governor, as you know, set deadlines which are coming up
fairly soon.
Yeah, I don't know. I suspect I've heard that they're making progress on that. I'm not directly involved in that in any way. You wouldn't want me involved in that. So I believe that they are continuing to work through that. I think I think they'll wait until the Supreme Court decides. There's a Supreme Court case that is asking the question around the legality under the Affordable Care Act of the federal subsidies on the federal exchanges. Now, we have a state exchange, and the governor had said if we didn't meet those deadlines, we would move to a federal exchange. And the Supreme Court case is King versus Burwell. So if the plaintiffs, and Kings are the plaintiff who is trying to argue that the Affordable Care Act has clear language that makes that the federal subsidies only apply to state exchanges, not federal exchanges. Now, there's 37 states that have a federal exchange. So if they win that case, then that throws a whole bunch of stuff up in the air about what are the federal exchanges going to do. Or some of them are already in the process of trying to become state exchanges. And whether or not the president then and Congress negotiate a deal, pass a new law, all that remains to be seen. So I don't think Vermont's going to want to, if the plaintiffs win in King v. Burwell, I don't think the state of Vermont is going to want to flip over to a federal exchange until that dust settles and they figure out that particular piece. So that decision is due in June. So waiting a couple weeks is probably good until the governor can see what happens with that case. If the government wins that case, then everything stays the same. And then I think switching to the federal exchange would be a real option to consider.
Just real quick before we go, we were talking earlier about, again before the show started, about single payer. I mean, I guess you folks in the hospital administration field probably had assumed that we were going to be moving towards a single payer program at some point down the road by 2016 or 2017. That looks like that's off the table for now. But do you think a lot of hospital administrators would like to see a single payer program? Because on the one hand, in theory, it sounds like that would simplify a lot of things. On the surface, it seems like that having one payer would be one less complicating factor in the equation.
I think no matter what you call it, I think hospitals would go for any system where the payments were predictable and sustainable, and I think that's what we're working towards. And I think we recognize that under the current system, now health spending, part of the reason, the drive for a single payer system, and I think the way the whole debate was framed was that single payer was going to fix everything. That once we had single payer, that healthcare would become affordable, everyone could have what they wanted. We still want, whether it's fewer payer, single payer, whatever you want to call it, we still want, and we're still working toward a healthcare system where we are gradually slowing the rate of growth, healthcare spending, to the general economic growth, because we're not going to have a sustainable healthcare system unless we do that. So we have to make healthcare good for our economy. And our strategies to do that are to change payment. So even though we have a multi-payer system, to get those payments from all those payers closer to being the same, which is, maybe you call it a virtual single payer if you can achieve that. Right. But to try to make all the many rules, federal rule and state rules and regulations, which are all over the place today, make them closer to the same for all payers, so that those dollars that are coming in the door are similar for the same services that are being provided, whether you have Blue Cross coverage or whether you have Medicare. So we're working toward that as a part of getting to a more rational system that makes sense. At the same time, as we were talking about before, having a delivery system that is helping, frankly, keep people out of the hospital, because that's where most of your expenses incurred. So doing a better job of making sure that Vermonters are getting the care they need, whether they have lifetime conditions, very complicated, expensive challenges, make sure that they are getting the care they need. But nobody wants to spend unnecessary time in the hospital. So get Vermonters the care that they need further upstream in a sense, and reduce the overall expenditure by giving that care up front where people tend to want it anyway, and saving the hospital bed for those who really need it. So that's, I think, the general plan.
All right. Well, I think we could probably go on talking about this for
we
a while longer.
Oh, I could talk forever about it, yeah.
But I guess our time is up for today, but I wanted to thank you, Bea, for taking the time to come down and talk about these very important issues. We've been talking with Bea Grause, who's the President and Chief Executive Officer of the Vermont Association of Hospitals and Health Systems. It's been our pleasure.
My pleasure.
Thank you all for watching today, and we'll see you the next time.